Congratulations on winning the lottery. Before you put it all in an index fund, I want to tell you about a drug called Blujepa. It treats urinary tract infections. Stay with me. 16 million American women get a UTI every year. 50% lifetime risk. 30% come back for another one. It is statistically one of the most reliable businesses in medicine, which makes it strange that the drugs we use to treat it haven't meaningfully changed since 1996. Meet Blujepa. Generic name Gepotidacin. Discovered by GSK, who apparently sat in a room and decided the name. Not bad as far as drug names go. FDA approved March 2025 for uncomplicated UTIs in female patients 12 and up. Then in December 2025, they added a second indication, uncomplicated urogenital gonorrhea, and I quote, in patients with limited or no alternative treatment options, which is a phrase doing a lot of work. 2 approved uses in 9 months. The label expansion story is already happening. Is the first mechanistically new class of oral antibiotic for UTIs since fosfomycin in 1996. Pharma tried for 3 decades. 2 new beta-lactams arrived in 2024, Pivia and Orlinva, but those are variations on penicillin, which was discovered by accident almost 100 years ago. Blujepa is a triaza-ace naphthalene. Pronounce it how you want. It's a genuinely novel scaffold hitting a binding site nothing else on the market shares. Now for the biochemistry. Bacteria need 2 enzymes to replicate their DNA. DNA gyrase, also called topoisomerase 2, and topoisomerase 4. They cut the double helix, let the strands pass through, and stitch it back together. Gepotidacin jams both enzymes at a unique pocket at the GRA dimer interface, which is a site fluoroquinolones don't touch. This does 2 things. 1, it works against bacteria that have already figured out fluoroquinolones. 2, because gepotidacin jams both enzymes with similar potency, a bacterium would need 2 separate mutations in the same cell to escape the drug. That is, in evolutionary terms, unlikely. That's a built-in resistance barrier. The trials. GSK ran 2 phase 3 studies called EAGLE-2 and EAGLE-3, they picked the name, not me, and published them in The Lancet in 2024. Over 3,000 women and adolescents with confirmed uUTIs were randomized to gepotidacin or nitrofurantoin, the current gold standard, for 5 days. EAGLE-2 said 50.6% therapeutic success versus 47, not inferior. EAGLE-3, 58.5 versus 43.6. That's a 15-point spread. One-sided p-value 0.0003. In one of 2 pivotal trials, the new drug beat the standard of care by nearly 15 points. That's what the FDA wrote the approval on. Safety. Diarrhea 16%, nausea 9%. Of the GI events, 69% were mild and 3% severe. The label also flags dose-dependent QTc prolongation, a heart rhythm thing, observed mostly in IV studies at doses that aren't approved. And mild acetylcholinesterase inhibition, I didn't say that right, because the chemistry is a little promiscuous. Both are manageable through prescribing restrictions. These are label warnings, not post-approval scandals. The competition. 4 generic antibiotics, most of them losing to resistance. 2 new beta-lactams from 2024, which beta-lactamase enzymes cheerfully chew through. And Blujepa, the only drug on this list with a mechanism nothing else shares, and the only one with proven activity against fluoroquinolone-resistant strains. It's not going to replace a $5 generic. That's fine. That's not what it's for. It's for the resistant, recurrent, hard-to-treat cases that nobody had a good answer for. Unlike most things in medicine, dosing is simple. 2 750 milligram tablets, twice a day for 5 days after a meal. Retail price is about $2,266 per course, but GoodRx brings it to $1,894. GSK's copay program gets eligible insured patients to just $30 per fill. That gap is what payer negotiations are made of. Welcome to brand pharma. Upside, label expansion is already happening. Gonorrhea was added 9 months after the initial approval. BARDA, that's the US Biodefense Agency, co-funded development because if someone ever weaponizes gonorrhea, this is apparently the plan. GSK is a CDC and WHO partner on antimicrobial resistance. No generic expected until around 2035. Risks? Honestly, payers will push back on a $2,200 antibiotic when a $15 generic still works. The QTC and acetylcholinesterase warnings narrow the eligible population, and the novel antibiotics have a bad commercial track record. I don't know how to say it. Aquagen, and Melinta both developed genuinely novel drugs and filed for bankruptcy anyway. The drugs were fine, the market wasn't. So the pitch is a novel molecule, real clinical data, federal co-funding, and 10 years of exclusivity against a market that has a documented habit of ignoring novel molecules. Triazosinethylamine.